Thank you, Bill.
Thank you for having me back. Right, so I'm going to quickly tell you about investigations. I showed you this chart before just to remind you that we couldn't reinvestigate all the baseline parameters that we did in the original audit. So take-home messages are, tryptase is still very useful, take it early. On the left, you see the chart of the timings in 5-minute intervals up to 15 minutes, and then 50-minute intervals or longer thereafter. And you can see that most samples are taken quite late, 15 to 30 minutes, 31 to 60 minutes. And that may partially explain this phenomenon that we see very few really high tryptases. And what we do now know from this data set is the tryptase falls really quickly within about 15 minutes. And that may explain all these people here who appear to have grade 3 reactions but no tryptase, but likewise grade 4 reactions here, but very little in the way of tryptase. This is the median, and those are the 25th and 75th centiles. That's the mean and the confidence intervals on the mean, and that's the confidence intervals on the median. And you can see that the grade 4 reactions don't really have that many more really huge tryptases. So on an individual level, no real correlation between the severity of the grade of your anaphylaxis and the actual tryptase levels. But this is confounded by this problem of variable timing of sampling. If you look at the grade 5s, you see this phenomenon that, again, there are people who die who don't apparently have any tryptase release. They may have only had one sample. We don't know when that will have been taken. And we had at least 3 mast cell tryptase available in 2/3 of the cases, which would be the optimum. We had 2 tryptases in 19%, which is 1 acute sometime within this time period and a baseline, and only 1 tryptase available in 8%. So, and again, you can see that the median tryptase is statistically significantly different from grade 3 and grade 4, and this is consistent with other studies, and surprisingly not awfully high. If you think of 14 as the 95th centile, that's only 14.9 in grade 3 overall, and in grade 4, your median is 33. Okay, with that approximately being the 99th centile for normality. So. Now, this shows you the difference in the tryptase results that we received in panel-derived triggers. So the panel has made up its mind what was the cause. So you can see that chlorhexidine looks very different from these antibiotics, teicoplanin and coamoxiclav, with nothing up here. Okay. Likewise, patent blue, nothing up here. And here's atracurium, very little up here. Statistically, this is significantly different from that. This is all muscle relaxants, the rocuronium and the succinylcholium, but is not statistically different from patent blue or atracurium. Atracurium is just non-significant. The P is just over 0.5. So it doesn't quite make statistical significance against any of the other muscle relaxants. But this is interesting. And of course, chlorhexidine, you'll remember, is the later presenter. And patent blue is the later presenter. So there's a chicken and egg here. Maybe you recognize it later, therefore you took your tryptase later, therefore your tryptase looks lower. Or there's something very interesting about the difference between drugs and their ability to release tryptase. Succinylcholium has a fearsome reputation for being a tryptase releaser, and indeed its median is much higher and statistically significant, but not statistically significantly different from rocuronium or the all muscle relaxant medians. So I'll leave you with those observations. Some triggers have a slower onset with lower tryptases, and these are the 2 that have been fingered in the overall report. That are very obvious. Patent blue and chlorhexidine. You can see it's 50-50 for chlorhexidine. The early onset's between 0 to 5 and 6 to 10 minutes, and with an awful lot of very late ones, and whether this is real or very late recognition or a typographical error, we'll never know. Atracurium, you might think there are some later reactions there, but it's predominantly an early reactor, just like all the other muscle relaxants. So we may be looking at some statistical artifacts there, interesting though these differences in the median peak tryptases and the maximums are. Dynamic tryptase, this calculation to get over the fact that tryptase overall seems to, peak tryptase or first tryptase, the maximum result in your series, isn't brilliant at defining the presence or absence of anaphylaxis. So maybe changes in a curve, evidence of acute release is better. So on the basis that most people believe that baseline tryptase doesn't change very much, not more than 20% in most people, a change in more than 20%, plus arbitrarily adding 2, may be enough to detect tryptases that never breach that 95th or 99th centile. So it looks as though it's within the normal range, but there is actually a curve hidden there. And that's what the dynamic tryptase algorithm does. You take the lowest value you've got, and the highest value you've got, and if you multiply the lowest value by 1.2, i.e. a 20% increase, and then just add 2, if your highest tryptase is above that, you have evidence of dynamic or acute tryptase release. If you apply that to this cohort, here, for example, if you use the European threshold for high tryptase, 11.4, that's the 95th centile in the UK population, or the one that, for example, many of us use in the immunology community in the UK, 14, which is the 99th centile. You find that you only pick up 76% of the cases using the 95th centile, and only 66% using the 14. So that is definitely less sensitive. But if you use dynamic tryptase calculation, just taking those that are under the 95th centile, you find you get 11% more cases identified. If you do it with the more specific 99th centile, you get 16%, so it's virtually the same. So dynamic tryptase seems to pick up all of these cases. So use dynamic tryptase, you'll like it. But you have to have 2 samples to get us 2 samples. One as early as possible, and then a baseline can be done at any time. Now, the other interesting thing is, and I learned a lot as we all did during this process, is about how we carry our preconceptions into the analysis of cases. So very often clinics will actually edit what they test for and on the basis of the likely culprits based on experience and the stats. And we know that most of these reactions happen within 5 minutes. So the smoking gun works quite well. So closer to the reaction, the more likely you are to potentially be a culprit. But not everyone tests for everything. But there's also the problem. Initially, we decided to grade them into what we called allergic anaphylaxis and non-allergic anaphylaxis, and then and there was a bit of debate at the time, but we stuck with that. And basically what we meant by allergic anaphylaxis is it looks like anaphylaxis, it smells like anaphylaxis, we're absolutely certain it is anaphylaxis, and 90% of the diagnosis in the history, and fantastically, they've got a positive test, positive tryptase, and a positive specific IG test, whether it's skin test or blood test. So they're all definitively allergic anaphylaxis. And then you've got your non-allergic anaphylaxis, which look the same, smell the same, have all the same characteristics, including the tryptase, and you can see the distribution is no different. But we can't get a positive specific IgE test. And the confounding variable here, of course, is that we're not very good at seeing these patients early. They may have false negative tests for a whole variety of reasons, or we might not have done all the tests, and therefore we know that there are differences between the tests. So these 2 groups are, in fact, essentially the same. And the really interesting thing is that in my head, I thought the tests aren't brilliant, that maybe they only pick up 60%, give us a diagnosis in 60%. That's either skin tests or blood tests for specific IG or combinations of those. But actually, it's much better than that. At least 3/4 you can nail a diagnosis that matches the panel confirmed diagnosis, but on the basis of a present test, and that in the presence of a specific IgE test, a skin test or a blood test or a combination of those. And that's despite the fact that we're lousy at seeing patients early enough for ideal, what we would regard as ideal sensitivity in this test. And the small number of patients where we thought there was it was truly non-allergic anaphylaxis. In other words, it didn't smell like anaphylaxis. We thought it probably wasn't an IG-mediated mechanism. You can see that it's at least partly driven by the fact they've got very low tryptases. And then there was another small cohort of about 16 in whom we really couldn't make up our minds. So, but all in all, 85 to 90% of cases in an experienced allergy clinic, you'll get a diagnosis with reasonable certainty. But negative tests don't make the reaction non-allergic. We had to be a bit more careful with our terminology. What about communication? Well, we could do much better. So we know from the baseline survey that there were acknowledged difficulties in the information that was given to patients, but we thought that we were better at communicating all the relevant important indices, like what drugs it was, what the mechanism was, what you should avoid, and all the rest. But actually, when we looked at the information that was provided in the forms, we thought there were actually some deficiencies in that. We knew we were bad at MHRA reporting, so this this is the previous survey I showed you in the previous set of slides, and this is all cases. And I pulled out the urgent cases, of which there were 29 NC-pod urgent, to see if we were any better at getting them into the patient pathway quicker. The answer is we're not. So, we weren't very good at MHRA reporting. That's how we thought we did. That's what we actually did. And we weren't really any better for urgent cases. Medical alert information, no, weren't anywhere as good as we thought we were, and weren't really any better for urgent cases. Letter to the GP, we thought we were brilliant, and we weren't bad. We were talking about, 70, 80% here, but it wasn't totally inclusive. Letter to the referrer, well, yes, we were pretty good at that. But actually, it looked as though we were slightly worse in the urgent cases. Maybe that was because we sent emails or had personal face-to-face discussions or telephone discussions, who knows. We weren't able to tell that. But overall, that wasn't too bad. Letter to referrer, reasonably good, but again, and we don't know why the urgent cases look to be slightly less good. Letter to the patient, we were probably slightly less likely to communicate that in that way to the patient as we were to the referrer and the GP. And written patient information, we were much worse than we thought we were. And safe alternatives, well, we all thought that we were very clear about what the safe alternatives were, but it turns out that we weren't actually, with only about a maximum of 40% in the urgent cases. So that wasn't great, and so there's room for improvement. What about delays in clinical assessment? Well, here's 6 weeks, and it is a bit arbitrary and the evidence isn't great, but we'd like to see patients around 6 weeks. Too early, we're worried about false negativity in the skin tests or the blood tests. Too late, we're worried about immunological memory disappearing, and therefore you no longer have a positive test. This is your 18-week threshold for UK-driven targets. You can see this distribution peaks somewhere about 12 weeks, which would be about here. So overall, the baseline survey was about right, but there's a huge tail. Look, going out to over a year, patients being assessed, goodness knows what went wrong there, and not many patients being done early, and not many of those were urgent. So in terms of testing, we've got not very good at identifying all culprits, only about 30%. Tended not to be great. This is 40%, remember, a maximum, at doing specific IGs that were available. We weren't really as good at, from the evidence that we'd had provided in terms of doing all the tests that were available and doing them in sequence. In terms of doing chlorhexidine, only about 60% actually did chlorhexidine routinely, and clearly if 75% of people are exposed, that's not great. Latex, although there was no evidence of latex allergy in the NAP6 outcome, again, we're still supposed to be looking for it, and we're not very good at looking for it. And the NAP6 panel wasn't brilliant because it was only about 50, 60%, but that was expected from the baseline survey. And what about quality? So overall, never mind all of that, judging against a list of perfection, what were the outcomes like? Well, there was room for improvement, but it wasn't anywhere near as bad. So against the strict headmaster of NAP6, only 10% of the assessments were said to be good. But a lot of the defects were relatively minor, and perhaps not having as broad a panel of neuromuscular blocking agents, for example, missing one or two of those, or the like. So 10% were good, but 49% were good and poor. In other words, they were pretty good, but they weren't quite optimal. But 41% were regarded as being poor. So there's the room for improvement. Were patients at risk following the allergy clinic investigation? Well, the good news is not from referral. There was an issue in that the panel often defined the fact that not all of the triggers, the believable triggers that were given very close to the reaction had been tested. And that was probably because we edited those out because we didn't think it was very likely and didn't do the test. The problem is if you don't test, you will never know. And we did find quite a lot of multiple positivity in this cohort, not explainable by family relationships between drugs. And unless you know it's positive, you'll never be able to risk assess it and determine whether or not it's relevant. So, you should test to everything that's been given. We thought that because of the inappropriate communication, 76% may potentially be at risk from inappropriate advice, not enough safe alternatives and the like. Inadequate communication with the patient was a problem, and communication with the team was also a problem in a subset. Diagnostic concordance, however, was very good. So 65% everybody agreed, another 22% the clinical and the panel agreed. And I'm running out of time. But the key findings are take tryptase early, use a dynamic tryptase algorithm, Failing to test, for tests for all potential culprits, do better communication, and we need more information on the predictive values of different modes of testing. And also see the patients early. We need better clinic availability and access. We need more capacity. And that's me done.
Thank you, Bill. That's excellent. I hope you're taking notes because there's going to be a question section at the end. So we all know Neil Maguire. Neil Maguire is the Clinical Director for Medical Devices at the MHRA. We've heard lots about the MHRA today, so we've brought Neil out of his cupboard and we've brought him back into the fold, and he's going to talk to us now on reporting and learning. Thank you, Neil.
Thanks very much, Kathleen.